Thanks, Gary, for that introduction, and indeed thank you for the opportunity to be here. Obviously, time won't permit us to do the Northern Ireland electronic care record justice in this particular session, but I'll reference some elements of that as we go through. As Gary mentioned, we have embarked on a Pathfinder program for a patient portal, initially targeted at a cohort of patients suffering with dementia. Quite a strange patient cohort to start with, and it presents its own challenges. The background to that was this has been mostly funded through a philanthropic organisation, that's practicing saying that one, Atlantic Philanthropies, who funded part of this and had a particular interest in the area of dementia research. So that opportunity presented itself, so we took that in terms of getting started on this patient portal journey. We built it purposely on top of our electronic care record, NIECR, because it has such a rich data set there. And it is an award-winning system. It's 40,000 plus registered users, of which about 25,000 use it actively in clinical care delivery. So it's a completely regional system. It's been transformational within our health service. So it made absolute sense to build our patient portal on that platform. The concept behind what we wanted to achieve out of this Pathfinder was we wanted to have this as a very patient-centered, citizen-led and citizen-owned portal. So the patient collaboration piece was very strong throughout, and we wanted to accentuate that patient ownership as we went through, and it really changes how we, within the health system, interact with our patients. So in terms of the vision for what we saw as a patient portal, using the NHS digital definition, we wanted this to be much more than a website. It needed to be dynamic, engaging, interactive and inclusive in terms of how it's used and what it's used for. And as I say, we wanted to actively involve the patient throughout this process. In terms of the phases of developments, we started back actually last year, 2018, in the development process. And just at the tail end of 2018 and into the beginning of 2019, we released phase one to our first cohort of patients. So they were able to see hospital appointments, the health library, and I'll explore some of the detail of those elements as we go through. Phase two, we're just about to release this month and into next month, and that will bring in further, more interactive functionality within the portal. And then finally, we've pushed some of the more complicated elements out to the tail end of the program, and that's something that we've been actively working on throughout. So we knew these were going to present some particular challenges, so we purposely left those to the end. And then also we'll incorporate any enhancements and changes that have come to light throughout the pilot. So that's the plan. Nice straight linear progression through. On we go to our finish line. Reality, however, probably resembles something more like this. Some of the particular challenges within this, and other speakers throughout today have mentioned this already, consent and capacity, particularly with the cohort of patients we are working with. Dementia patients, at the point they are not able to give capacity to share their record with a family member, for example, is the time at which the family member gets the most utility from it. But feedback and advice from the Information Commissioner's Office tell us that has to be regular informed consent from the patient. In Northern Ireland, we don't have lasting power of attorney covering health as yet, so those types of challenges translated into that non-nice linear straight path towards development. Other challenges around cybersecurity, we absolutely had to make this safe, secure. We are essentially allowing the patient right into the heart of our health system. into our most prized asset within NIECR. So the cybersecurity elements were very important to that. So we've undergone extensive penetration testing and ethical hacking around that, and our colleagues in Orion have been fantastic in terms of the architecture of the system and working with us to satisfy the requirements of those particular audits. Other areas that we have encountered is general health literacy and the variation in health literacy across our citizens and patients. So some patients are very in tune with their condition, very knowledgeable about it, and want a lot of that detailed clinical information to help them manage their own condition. Others less so, and the information has to be maybe tailored or presented in a different way. So those are all the challenges, and this is probably why we call it a Pathfinder, because we are exploring these as we go. So the patient onboarding process, the invitation for a patient to sign up to the patient portal is issued from within our NIECR. So the clinician could do that in a conversation with the patient, say, look, I think you would benefit from use of the patient portal, here's what it's about. So within NIECR, with that patient's record open in context, they will send an invite out to the patient, and the patient can then accept that through a time-bound link that they respond to. When we look at progressing this to a wider cohort of patients, that might not be a sustainable model. So we're going to have to think about how we can engage a large number of patients appropriately in that type of context. But for now, that's the process we're using. The login screen is very bland. We have branded our patient portal as My Care Record. We incorporate health and social care in our health system, so it's not just a health record, it's more encompassing than that. Although Karen and I were just speaking earlier, the Engage platform, even the word engage, maybe, engage patient portal or engage care record or something might work well also. So, but for this particular cohort of patients with dementia, the feedback was they wanted this to be very bland, very plain background, but maybe as we progress through, we can be a little bit more imaginative around the presentation of this. Because the system allows patients to interact with their clinicians and share information with clinicians, we had to be careful that this wasn't seen as a way to contact clinicians in an emergency situation. So again, these are lessons learned throughout the Pathfinder process. So we had to put a disclaimer up that said, look, this is not for emergency situations. Use your traditional methods for that. Because there was also a concern from clinicians to say that if a patient puts something up that they were obliged to respond to in an emergency situation and could land them in trouble. So again, legal advice and so on was that this disclaimer should help resolve that particular issue. So it's all of these little things that we have unpicked as we went through the Pathfinder. Phase 2, as I mentioned coming out, we're coming up with a fresher interface to it. This is moving towards the React mobile type platform that Orion have been working on the development. So again, to make that more mobile friendly, more device agnostic across. So that's something we're looking forward to seeing as well. In terms of phase 1 functionality, one of the most popular elements of phase 1 was the ability to go in and view past and upcoming appointments for the patient. So initially that's on our core patient administration systems in the acute setting typically. Although we have, in this current release coming out, we're also hoping to bring in community-based appointment systems to be able to view appointments outside of that acute setting. We could use this tool to do appointment booking if we didn't have 8 different PAS systems and another plethora of different patient administration systems of different types out there. So it's things like that add to that complexity rather than the tool itself. The other piece of functionality in phase 1 was a health library. You all know if there's a particular medical condition or medical concern you have, and you go onto Google and you get a plethora of different advice and guidance. It can be very confusing. You just don't know what's relevant, what's not relevant, what to believe or not to believe. So the health library is a properly clinician populated library. It's curated. So the information within that library then is tagged, and the patient, depending on their different conditions that they're tagged with, can find the relevant information that more closely matches their particular need at that particular time. So that's a built-in library that we then use to, you can maybe just about make out on the screenshot some of the groupings there that you can set the tags against. So that the health library is also a very popular piece, and we've had a lot of support from our clinical colleagues in terms of populating that library. You know, they really have got on board with that. Shared files is a similar concept to the health library, except it's a two-way sharing of information, and that can be in different formats. It can be Word documents, PDF documents, video clips, and it's two-way, so the patient can upload documents, video clips, whatever, into the system, and equally the clinicians can share directly with a specific patient through the system as well. In the dementia context, there's lots of different use cases potentially there. So if a patient is maybe at a memory clinic, their normal performance is maybe a little skewed by the environment that they're undertaking that particular memory test in, whereas a family member could record them doing that in their own home in an environment they're familiar with, and that could be uploaded, and it'll give the clinician just a different perspective of that patient. So very powerful, really starts to open up the interactivity between the patient and the care delivery system. Phase 2 that we're hopefully about to release in the next month or so is around presenting clinical documents out of the NIECR to the patient, beyond the elements that we were sharing in the shared files aspect. There's some relatively non-controversial clinical documents that we can immediately start sharing, are things like discharge summaries, letters that you would typically send out to the GP after an inpatient stay, for example. So those types of documents we've got agreement on, and we can move quickly with those. Other documents that the patients are asking for, some of the clinicians are concerned that the very medical style of those documents, the language used might create more harm than good for the patient if they don't quite understand those, and might cause some anxiety and concern. So there's that tension already developing between what the patients are telling us they want to see and maybe what some of our clinical colleagues are comfortable about sharing. So again, this is all part of the joys of a Pathfinder project of this type. The Circle of Care is already in operation. It allows patients to add other people into their circle of care. So that could be another contact, or a neighbour is holding the key for the patient to gain access, or whatever it happens to be. But the patient can also choose to give full representative access to a family member or a friend. And that's the area, for example, where the consent issues with this particular dementia cohort comes into play. But it's a very, very useful facility for our patients to have and for their family members to have. The third sector, independent sector, could also be potentially involved in using this, as well as other parts of the HSC can input all of the people who are involved in that particular patient's care. Goals will also be released in this particular phase coming up. So the goals, there's a number of inbuilt goals that can be set as target achievements over time to hit particular ranges, and that could be smoking cessation, weight loss, more social inclusion, blood pressure monitoring, whatever set, so that those can be agreed in conjunction with the team of healthcare professionals and the patient, and then those goals are input to and updated as the patient progresses. And again, this is all part of this involvement and ownership from the patient in their own healthcare. We do, for example, have a very, very high utility diabetes pathway within NIECR. The diabetes patients, this would be a really useful tool for them to be able to interact with in terms of the patient portal. One of the areas that our diabetic physicians say is that they struggle to engage adolescents in their care of diabetes. You could maybe take the goals and gamify it a wee bit and try to make it more appealing to that cohort, because it's maybe a format that they would more readily interact with than the traditional format. So there's lots of potential with this as well. A lot of the settings and how the system is used is tailorable by the patient. So there's a whole suite of utility there that the patient can go in and change their account details, passwords, what people are allowed to see or not allowed to see, what representatives have access, and so on. So again, a lot of this is configurable by the patient. So phase 3, I mentioned, is where we start to get into the slightly more challenging aspects of our patient portal journey. Medications, we obviously have a lot of that medication detail and data within the NIECR. It's how that's presented to the patient. The patient's maybe not overly aware of the brand name or the drug name. They just know they take a little white tablet at whatever time in the day or happens to be. So again, how we present that information in a way that's consumable by the patient where they are in terms of their information. But the idea of this is then that you can simplify the views, or you can get it that you can drill down, look at more detail on a specific drug information. So that's something we have to be careful with, even in terms of the completeness of that record. So, is this every drug that the patient's taking? In the same way as we have lots of alerts in our NIECR medications screens around, please check a secondary source. It's important really to get that message out to the patient. This might not be, or the family member, for example, that this might not be everything that the patient is taking. Similarly, laboratory results. Given the nature of some of the conditions that the patients could have, what is a normal range? How do we present that information that is safe, doesn't cause undue alarm, is beneficial to the patient? So that's where we're struggling with at the moment. And again, with the dementia cohort, it's maybe not the best cohort to start with, whereas if maybe a diabetic group, in terms of the lab results that they have, they'd be more in tune with that, or renal patients, or whatever case may be. So even just testing that at the moment with that particular cohort, we're trying to find patients who have quite a good mix of a drug and a laboratory result history there. So lessons learned from phase 1. Basically, there were things we could have done differently or could do differently around the onboarding process. The consent to share information was a big challenge. As I say, the appointments screens were the most popular. That was of high utility. And when we start to bring in the community appointments, that will be even more better received. The health library was very useful for patients, especially just at early diagnosis, first diagnosis stage, where they had lots of questions and they were able to go in and get that information easily at that side. The circle of care piece wasn't overly well used by our clinical community, so we want to encourage them to populate that circle of care piece better, or look at ways how we can auto-populate that better on their behalf. So where next? Obviously, there's lots of other functionality that we would like to bring into this. Martine will speak in a second about the remote patient monitoring element that would lend itself very well as an extension of this. Other pieces of functionality that we are actively looking at the moment are questionnaires, so you could have your preoperative assessment information sent out through the patient portal, let the patient complete as much of that as possible at home. We have a lot of interest from orthopedic colleagues, for example, on patient-recorded outcomes post-surgery. So there's lots of potential use cases for that as well. We have a long list, as you can see there, of other specialties and cohorts that are knocking on our door. And that's actually quite a privileged place to be. Early on in this journey, we had to fight the battle of competing against condition-specific patient portals. So we made a strong case to say, look, that's going to be confusing. Patients don't neatly fall into one particular cohort. They'll have a multitude of comorbidities, co-conditions. So we wanted to establish this concept that this patient portal is pan all of those conditions. So now we have set our stall out in that regard. So we have got this queue of other conditions wanting to be part of this journey. Other areas that particularly interested and would have a really good potential use is things like maternity handheld records could be digitized, and the red book, for child health and so on. So there's lots of exciting opportunities coming with this. So that's a very whistle-stop tour of the patient portal journey. I appreciate it's hard to do it justice in this time, but we really would welcome anybody that wants to come across to Northern Ireland. It's a lovely place to visit. The sun's always shining like this. So we would be delighted to host you and share some of what we're doing. And it's also been very inspiring to hear the journey of other folks throughout today. So it's really gives us a lot of enthusiasm for going forward with this. So thank you very much indeed.